and that's the guidance from the Chief Coroner in England. We want to ensure that's timely and accurate, and their clinical governance concerns. So it's detecting early patterns, it's detecting concerns, it's detecting learning, and that's for us to feed back internally within the trust and more widely. And why was this needed? Well, it's all about improved communication with our families, improved communication between junior doctors and senior staff, and identifying where things have gone wrong or where there's things to learn. And we can all go through case notes, can't we? And there's always a catalogue of things where we could have done better. But it's really important that if we're going to change care for the better, then we need to be open, honest, and share where people have made mistakes as an organisation, or we've learned as individuals. And if we're not sharing that, we're not really giving advantage to our future colleagues and future patients. We want to make sure that the death certificate is accurate. So we know before the pilot work with Medical Examiner Service, a huge number needed to be changed, and about 40% of things were felt to be inaccurate before the Herald sites. There were about 10 hospitals in the country that started about 10 years ago. And we have been able to reduce unnecessary coronial referrals. It's all about improved care for our patients, and certainly never a tick box exercise. So what's the process? Well, we deliver a proportionate review of relevant records, so in hospital that's easy because we have access to all the systems. In interacting with you guys, so therapists, nurses, junior doctors, often you're referring to us via Panda. That's enough often. Where we need more information, we're having a conversation with yourselves as a two-way communicate, and then we come to a final decision. We have a discussion with the bereaved in every occasion, or rather I should say we offer a discussion with the bereaved on every occasion. Rarely it's not taken up, but it's the opportunity for them to raise concerns or to have some questions asked, and that's to help with their bereavement, with their understanding of the causation of death. And it ends, of course, in the confirmation of medical certificate. And if we look back and think around deaths in an acute hospital, most deaths in an inpatient setting, so that's separate to A&E, most deaths we predict, don't we? So we know when someone's dying, we predict those last hours or days, and so we are able actually to think about as a team what our patients are dying from, and really documenting that and being clear as a team. We also need to consider what their faith needs are, and there's an option of a pre-death referral to our service where you can highlight that earlier, because there are certain faith groups where burying a body very quickly after death and with the aim of offsetting so if possible is really important, and so whatever we can do as doctors to help that happen is really key. So I'm sure you've probably all seen this slide already because I think it was shared in induction, but it's just a reminder, this is from the trust, that when a patient dies and the ward is actively dying, we should be thinking around the causes of death, we should be discussing at the board round, checking with the registrar and the consultant, and then when the patient's passed, doing that PANDA referral really early, and then getting the note off to the bereavement office via your ward clerk. And the more engaged we are in the process, the quicker that's going to happen, and actually the less unnecessary calls you guys need to receive. If we do it in a timely manner, actually it's probably less work for yourselves longer term. And it certainly gives the family that closure, which is really important after what is a really painful time of a death of a loved one in an acute hospital. So how can you refer to us? It's really easy now, because actually you can just click on the clinical referrals button, and from that, in Affinity, you can get straight into Panda in the patient context. You can go through Panda as well, here, but actually you can now go straight through there. So it's really easy. We don't want huge amounts of prose, so please keep it short. A sentence is absolutely fine in terms of the narrative around why someone has died from the disease you're proposing. When you're needing to do a coronial referral, having that key information is really important and a bit more in there. So it's, imagine you're talking to the coroner, to an intelligent layman. So they're not doctors by training, so you need to not use any abbreviations, try and keep the jargon as minimal as possible, and just tell the story of why, how, why, and where a patient passed, and that will keep things a bit quicker for yourselves. You don't need to go into minutiae detail on these forms. So we talked about the medical examiner. Let's talk about the coroner. So they're an independent judicial officer appointed by local authorities. They're either doctors or lawyers. In our region here, only one of our coroners is a doctor. Historically, it was you could be a doctor and become a lawyer. And become a coroner without being a lawyer. But I think it was about 10 years ago or so they changed the law that you had to be a lawyer. So actually now most coroners are lawyers, and the numbers of those who were historically doctors are retiring out. There's lots of reasons to refer to the coroner. It's not about there being a problem, it's not about there being a failure in care. It's most commonly due to a simple legal duty to notify. And the outcome most commonly is not an inquest. Most commonly it's signed off as a natural death as a sequence of events. So I know it's always worrying when we have to do anything to do with the coroner because it sounds scary, but actually most of our referrals end up in simply natural signing off of those and a progress to a death certificate. So who do we have to refer to the coroner? Well, the Justice Act of 2009 stated that the coroner's inquest is to define how, when and where the deceased came by his death, and any particulars required by the Birth and Registration Act. It's inquisitorial rather than adversarial, so that means as in it's not a cross-examination, it's simply trying to define how, when or where the person came by their death. These are the reasons why you would need to refer to the coroner. So the top one being pretty obvious, where we don't know the cause of death, and that really does mean when we don't know the cause of death. So sometimes we get referred to cases from both primary care and secondary care that clinicians aren't 100% sure of the causation of death. Does anyone know the level of certainty that we need for a death certificate? So in a court of law, what levels of certainty are there? So, anyone know? And watched American sitcoms?
Like beyond reasonable doubt.
There's beyond reasonable doubt, so that's like pretty mega certainty, isn't it? Then less than that, what's the more lower than that? If it's on balance of probabilities, yeah, so that's on balance of probabilities, this is more likely than that. So that's kind of in the middle. And then you've got to the best knowledge of the treating clinician, and it's that level of certainty is required for a death certificate. So the best knowledge of the treating clinician. Yeah? So that doesn't mean we need all the tests to be confirmatory. It means we need to have some reasonable consideration that that is the cause of death, and usually that's with some symptoms, with some signs, with some tests in a hospital setting. So if we don't have those and we really don't know, we need a post-mortem. Obviously we need to refer to the coroner. If it's unnatural, so what's an unnatural death? Got stuff on this list. Yeah, knife in the back, that's pretty unnatural, isn't it? So if you come in and there's been a violent act, that's unnatural. Poisoning, unnatural. So death as a result of a human intervention, of a medical intervention that's gone wrong, that's an unnatural death, so that would be inquestable. Anything that's occupational or industrial, again, that could be an unnatural death. Now, it used to be, if you're on a doles, that was an indication to refer to the coroner. That was removed some years ago, but still, if you're in custody or under section, so under mental health section, again, that's an inquestable area. So all those things on there. This is a little summary slide around the changes to the death certificate. So you'll have all had a go at doing the death certificate since September last year. You'll be used to the fact that there's an additional 1D on there now, so there's a bit more space to write more stuff. There's the new pregnancy questions, ethnicity questions, and medical devices. They did miss a trick when they called it medical devices. They should have written hazardous medical devices, shouldn't they, instead of writing any medical device. But in Gov UK on the cremation paper guidance, there is a list of hazardous medical devices that you need to actually be concerned about as a doctor. So what does the Office of National Statistics say? Well, they say please be specific as you can. So they've used some examples here. So pleural mesotheliomas, that's the disease and the site. Coronary embolism rather than embolism. They like the source cancer with metastases. So if you've got the ONS looking at the data from death certificates, if you write metastatic lung cancer, although to us it seems fairly obvious that we're talking about lung cancer with metastasis, actually the laymen say, well, actually we're not sure if the doctor's saying that the metastatic disease is spread to the lung or whether the lung's the primary. So from an ONS perspective, actually saying lung cancer with metastasis is, they find that more helpful. So that's sometimes why we encourage people to write things in that way. Abbreviations, never use abbreviations. Yeah. And failure, the only one you're allowed is cardiac. You're not allowed any other failures as primary causations of death. Any questions so far on those things or disagreements? So we've talked around when do you need to refer to the coroner and how that works. What happens next if there are concerns internally? So say we had a look at a case and there might be some feedback from the family, there might be some feedback from you guys, the team. You might say we were quite concerned about this happened or this didn't happen, or there may have been some data excess going on. Internally in the trust, there's some formalised processes that sit alongside the National Mortality Case Programme. And our trust performs an annual report, which you can all look up online and read. It's available for the public. We have an internal review system called the SJR, and that's a subjective judgment review. So that's a pool of clinicians, not just doctors, who look at the content of a case to ascertain the learning and the outcomes from a trust perspective. And they're trained to give written, short, explicit clinical judgments on quality and safety phrases of care. And as MEs, one of our roles is to facilitate case finding for this team. So they look at the first bit, the middle bit, and then the end bit of care, and then give a mark for the overall portion of care, and importantly whether or not there was potentially an avoidable death. So I think to try and frame the context, what does this mean for us as a site and as a trust? You can see that sadly there have been potentially avoidable deaths at our sites. The numbers are relatively low, but they are happening, so that's important for us to reflect on. These are the learning themes from the SGR. So most of it's around delays to assessment or treatment. Yeah, so a lot of us notice there's challenges, isn't there, across our zone E's with patients sat in corridors, and I saw a number of patients on the acute take this morning in A&E who were, should be in medical or elderly care beds or surgical beds. Communication ceilings of care, DNA CPR, so that's again quite a high area that we can all do better on. Issues around end-of-life care, clinical decision-making, lack of senior input or TEP. So all these things, some of these things are within the sphere of our control, aren't they? So doing TEPs and defining what's medically futile, we can all do that, and it's your job's to poke the consultant if we haven't done one. Say, actually, Dr. Williams, I can see the patient hasn't had a TEP, have we decided what we're going to do if this patient deteriorates towards the weekend? So do engage your teams and have those discussions, because we can make a change to these things. There's also some really nice stuff that comes back from the whole process. And this is a word map of positive feedback that we get for you and your teams from the ME service. And although we have some negative feedback, we get a lot of positive. So excellent care, caring staff, praise, kind, grateful, lovely and respectful. So all really nice things to hear and motivating for teams. Again on there, that's some feedback areas from medical examiner service. So very similar to the SGR teams. So we've gone through what are those three sections inside the trust, the coroner system and the ME system. I thought what it might be useful was just to go through a couple of cases where you can help define the causation of death, and we can use these as a talking point. So a 66-year-old man with a recurrent TIA started on dual antiplatelets. He's got severe carotid disease, classical risk factors, comes in for elective carotid surgery, has his operation 4 days after his TIA, so not straight away, but it's in a reasonable kind of time frame. And he develops an intraoperative complication with a shunt and so overperfusion within the brain, and sadly has a bleed and drops his GCS, and unfortunately passed away in ITU some days later after that. So, thinking around causes of death, when you're writing the referral to the medical examiner, is that one going to go to the coroner? What do we think, having reflected on the indications for coronial referral on the earlier slide? Any takers? Who's going to refer to the coroner for this one? Only a couple of you. Everyone else not referring? Who's not referring to the coroner? So a few undecideds there. Okay. So you have to make a decision. Not deciding something is the same as not making a decision. So we're going to refer to the coroner. Yeah, I think that's sensible. What are we going to put in 1A, B and C?
Can you put surgery complication?
You can kind of put a narrative in there. Yeah, how would you write that how would you propose it to the coroner, do you think?
I mean, that's just the words surgery complication as the cause of death.
I think just putting surgical complication might be a bit vague, because remember, they're not doctors. So if we track it back, so what was the mode of death? What was the thing that caused the deterioration in that case? Intracranial hemorrhage, yeah. So you might have the top one, 1A, the mode of death, so that's intracranial hemorrhage. And then what caused that?
Intraoperative complication.
Yeah. So you could have 1B, and you could put your operation, so carotid endarterectomy, date with complication, or you could just put carotid endarterectomy, so we're saying that led to the bleed. Would you leave it as that, just with a 1B? Or do anyone think we could put anything in 1C?
Carotid stenosis in C.
Yeah, you could have carotid dystosis with TIA in C, because that's the indication. Because the coroner kind of wants to know, if we didn't do the intervention, what would happen to the patient? So if we hadn't done the intervention, the patient might not have died. I mean, they could have done, because they could have had a massive stroke and died, potentially. That's a what-if scenario. If we hadn't done the intervention, they may have had a significant stroke quite early in that first 2 weeks. We had an intervention, we had a rare side effect, because the risk of having the hemorrhage or this complication is really low, actually. So we could write perioperative intracranial hemorrhage, carotid endarterectomy 1B, 1C treated recurrent ischemic TIA, or you could have, as you suggested, severe carotid disease with TIA, or severe carotid disease would be fine. And then in 2, the risk factors of smoking and hypertension were quite important there as reasons for the atherosclerosis, and hypertension as well potentiated the hemorrhage, so that would go off. That's probably going to be inquestable because it was as a result of human intervention. Doesn't mean anything went wrong, doesn't mean the surgeon did anything wrong. Consent was absolutely appropriate. And if we write a really good referral, sometimes we can avoid having to do another report for the coroner. So that's where the information of the coroner is really important and being clear to them. So next one, 64-year-old lady, out of hospital, cardiac arrest. So it was witnessed arrest, and she had bystander CPR, and she had ROSC in A&E. On her ECGs, there was ST depression and leads V1 to V3, and a prolonged downtime. Remember, she only got ROSC when she got to A&E, so quite a long downtime. Hypoxic ischemic brain damage was suspected, and imaging was consistent with that. And the team in A&E did a CTPA, and they didn't find any evidence of a large vessel pulmonary embolus. She went up to ITU and had no signs of recovery, sadly, and organ donation was considered, and I think that in this case, successfully, some organs were harvested. So what are we thinking? What's the most likely cause of death? Have we got a clear cause of death there? So thinking about on there. So any thoughts? Have we got, if we were in A&E, so I've got a couple of people in A&E here I can see. If they came in, what we think's the cause of death? What's the cause of the cardiac arrest? Can we put cardiac arrest? I looked at a death certificate the other day and it said, what did it say? Out of hospital cardiac arrest, 1A. Is that acceptable? Any thoughts? Is that alright? Is that a disease? It's a mode, isn't it? It's a mode of death, so you can't have a mode of death unqualified. It has gotten through in the past through the coroner, but it's not really acceptable. So, what do you guys think the most likely cause of death here is? MI, yeah. And that comes back to like the level of certainty. So we get this a lot with queries, like, oh, we didn't have the troponin before we started doing CPR. We've got ECG changes. We know it's not a massive pulmonary embolus. So we're left with probably a myocardial infarction. That feels reasonable. The clinicians are comfortable with that. So you could have hypoxic brain injury, 1A, out of hospital cardiac arrest, 1B, again another mode of death, with C, a cause of death, acute myocardial infarction, risk factors in 2 that are important, which are contributory to the death, or just keep it simple, keep myocardial infarction and the other stuff in 2. Third one, Alzheimer's dementia, so increasing care need over the last year, severe heart failure, ejection fraction 15%, presented with a fall to the floor at home, edema to the abdomen, short of breath, hypertension and delirium, so all those kind of poor prognostic signs. CT brain, no bleed, no rib fractures, urine showed E. coli, progressive renal failure and chest X-ray with interstitial edema, unsurprisingly developed refractory acidemia and breathlessness and died. Do we need to refer to the coroner for this one? Patients had a fall, presented with a fall. What do we think? Not anymore, no. Interestingly, about 5 years ago, anyone with a fall had to be referred to the coroner in this area. It was part of old-fashioned local rules. But since the medical examiner's service started in 2020, we've moved away from that. So now, it's if you've got a traumatic injury that's led to death, obviously you'd have to refer because that could be an unnatural death. But this was a collapse, wasn't it? The patient was ill, had hypertension. Good. So what are we going to put as cause of death here? Any takers?
Either an UTI or decompensated CCF.
Yep, and I think, it's how it comes across. Is it predominantly sepsis with hypertension as the driver, or is it volume overload with falling off a Starling's curve and hypertension? So down to you guys in terms of arguing which one it is, and either of those is acceptable. So you have end-stage heart failure. If there's a chronicity to it, if the patient was relatively stable then fell off the cliff with sepsis, you might argue it being a coli urinary tract infection in 1 and the other stuff in 2. What if the patient had rib fractures on the chest X-ray and volume loss in ipsilateral but no pneumothorax? What do you reckon? Sometimes we get these sorts of ones. Unwell patient had a fall,
Yeah,
got some damage.
still natural.
Still natural. Yeah, I agree, yeah. I think if they'd had massive pneumothorax or huge hemopneumothorax or something and it impacted on the mode of death, we might have to notify the coroner. I don't think they would be particularly interested in taking that forward. But yes, there's been some injury. No, it hasn't contributed significantly to the death, so it doesn't matter.
It depends if someone pushed there, right?
So the coroners do take how it happened into consideration. So if someone had a fall at home, and I guess then what's a collapse versus a fall? So if you've got severe heart failure, you've got poor LV, you've got hypertension, you've got low cardiac output, and you collapse at home, so then that's a natural death because it's the end state of a disease. if you're walking outside Waitrose, uneven footing, and you fall over because the paving is really uneven, yes, you might have Parkinson's disease and gait instability, but actually there was some failure of the council to fix the pavement, and you have a situation where someone died, the coroner's probably going to take that for an inquest. So absolutely, what happened, how did they fall? So the coroner really likes to know, where did it happen, why. So on the ambulance sheet, that's the bit that they like to know. They don't really care so much about the minutiae detail of what happened in the hospital. If someone's had a fall and you're referring, it's how did they get it. So was it actually a seizure outside in the car park of the hospital? We had one who'd been discharged from A&E, not inappropriately, but then had a seizure, sadly, collapsed in the hospital car park, had a big head injury, and sadly passed. That needed to go to the coroner. And if someone pushed them over, we had ones with violence in a care home. So one person was psychotic, pushed somebody down the stairs. The coroner needed to know those bits. Those bits were on the ambulance sheet, but didn't feature in the medical record, because by then Chinese whisper had happened. We'd lost that actually there'd been an act of violence in the care home. So have a look at the ambulance sheet, really important when you clerk your patients in. It gives you the information that you need. Cool. Any questions for those ones? Is there people left uncertain about stuff, or is that left with an uneasiness from anyone that wants to ask anything? No? Because sometimes we can overcomplicate things, but I'm trying to simplify stuff for you guys. So I've got some cases. These are real life ones, and you'll see that it's a bit of a challenge to navigate the medical record because it's how we all write. So I've got 3 cases. So should we split into kind of 3 groups? We've got sort of, how many have we got here? 1, 2, 3. So maybe we need a couple of people from this group to join the back. Maybe you guys on the back row join the back group. So we've got 1, 2, 3, 4, 5. You've got 5. You've got 1, 2, 3, 4, 6, 7 here. So yeah, why don't you join the back row, and we're going to do 3 groups to discuss some cases. So I'm going to give you guys case 1. Have a look through. So maybe you want to get around and there's 3 sections to it. So that's 3A. The discharge summary. And then this is the notes. So have a look, we can line up the bits of the record, have a look through it together. And I want you guys to think about, for each case, is the causation natural? Is there a duty to notify the coroner? Are there any potential clinical governance concerns? And that bit's really important. So as there's some learning that you're spotting that things could have gone better. You guys will give you about 7 to 10 minutes to have a look through as a group, and then what we'll do is we'll feedback group by group at the end of that. And if you've got any questions or need more information, obviously, you just come and ask me. They might not be in chronicity order, because I think the filing could have been slightly dodgy as is in real life. Yeah.
Oh, the nurses. What happened between, like, is there a consultant?
Which particular person you've got?
Just a parking consultant. Just review. Well, Thursday.
Oh yeah, so I'll go. Wonderful. Let's see. Yeah. We don't know which one first.
Yes, I think this one actually which is why it's really weird.
There's like with F1 being like, I'm scarred.
Yes. Because it's quite a bold thing, and that's why I recognise some of the writing. This is a that's right, yes, it's a consultant helping the patient through that one.
They should have put that on the top.
They should put it in there because it looks like
It looks like it's F1, yeah.
Yes, so maybe that's in the
It's a learning point.
Sound, I love it. See some of the consultants on the right. I put their name straight at the top. I'm like,
Oh yeah, so this one, for whatever reason, this one has
also, we love traffic highlights.
Yeah, I would have thought this.
Well, the F1's definitely round. Because they signed, the F1 signed it off.
It's a while ago,
Yeah, it's a really nice. Yeah.
like single sheets.
Oh, yeah, true.
So sometimes.
Because they have a template, right? They keep saying how they have a template. They have a
So my question, I guess it's on the street.
No, because of
Yeah, so there is room jump.
my question is, what images do they have? Because they might have a template, right? Based on this plan, they just like did they have a template in A&E for the information? I'm sure share the maps and
Ignore the confidential because I have to hide it.
they don't really have to be seen by friends, like really factual.
So what, last minute or so?
Further escalation would be inappropriate. Requiring 40 years of
They weren't responding to treatment.
She was one of Edinburgh, the country. We don't know the
Why are you wearing heat?
Oh, is it? Sorry, last job. Oh, really?
She was
I think it's calls in the day.
Cool, so that's about 10 minutes. Okay guys, so I think that's about 10 minutes or so we've done now. So if you want to bring yourselves back into the group, then I will ask each team to kind of present a short summary of the case and what you thought in terms of causation of death. So should we start with group one? You guys at the front, group one, where? So thinking about the case, give us a short summary and what your thoughts about covering those areas were.
So a summary about the.
Give us the headline summary for the rest of the people in the room.
Okay.
Just kind of an overview of what happened with the patient.
So our patient was an 84-year-old chap with a history of type 2 diabetes and small cell lung cancer with liver mets. Was found by his son in the early morning, unresponsive and vomiting around his mouth. Was brought in by ambulance. On arrival with the ambulance crew, his blood sugars were 0.8. He's type 2 diabetic on insulin. He was also febrile when he was with the ambulance crew, and was noted having kind of jelly babies with him at the site in his house. He was on his 4th round of chemo, which he had about a week or 5 days earlier for his lung cancer. And in A&E, he was, when he was brought to A&E, his blood sugars had normalised. He was given plazocin, gentamicin, morphine, and buscopan. It gets a little bit confusing because the story's a bit unclear, but essentially it looks like he was kind of popped onto the palliative, he was given palliative care meds, was reviewed by the palliative care team, but it's unclear if they were, planning to kind of actively treat or not at that point. Palliative care saw him later that afternoon the same day. They agreed that he was probably dying. They recommended continuing PRNs, have a low threshold for a syringe driver, and then it's documented in retrospect in the nurse's notes that evening that he had passed away and the family had been updated.
Is there a documented verification of his death in there? No, so that's missing. But there's a retrospective.
It says written in retrospect, patient has passed away, and that's stamped by an NMC member.
What did you guys come up with in terms of cause of death of the patient then? There's no right and wrong answers, don't worry. What did you think was 1A then? So the patient had severe hypoglycemia. What could that have been caused by? What were you thinking?
Could have been from taking too much of his insulin.
So it could have been insulin overdose.
The son also reports that he doesn't often eat. So
Yeah, so it could be taking insulin, not eating anything because of the cancer. That's potential. Or maybe was it sickness because of nausea because of chemo? Okay, so that's one potential cause. Another cause of hypoglycemia. So A&E started a treatment regime, didn't they? Cover that. So what else causes hypoglycemia?
Infection.
So sepsis. Yeah. Yeah. Anything else in this case that might cause hypoglycemia? Relevant to the past medical history of the patient. Anyone else want to help out? So we've had sepsis, insulin.
No any steroids.
So if they have been on long-term so Addisonian type crisis, yeah, that's a good differential. Anything else? So liver. They had liver mets, didn't they? So potentially liver failure as well. So we've got a number of things which could potentially, yes, you might want to explore, ask the questions, around, did he take his insulin? Did he take too much? What happened? So what were we thinking? Do you think that's unnatural death or natural death? So someone's come in with, severe hypo, life-threatening hypo, and then develops further hypoglycemia and dies. What do we think? In the context of having had recent chemo and metastatic cancer. If you were the ME and you had that information, what are you going to do? Do you have a duty to notify the coroner?
Yes. No?
Well, it kind of depends on you see. Want a bit more information, don't you?
I think if he'd taken overdose on the insulin, maybe probably would.
Mm-hmm.
If he'd taken kind of his normal course and just hadn't eaten, he would.
Yeah, because his disease was affecting the way that he was going to react to it. He didn't have any glycogen storage anymore. His liver's failing. So that's a natural death, isn't it? But you're right. If he'd accidentally taken or intently taken an overdose of a medicine or product, it's unnatural death. So we want to ask those questions. Cool. Okay. So and if it was a natural death, are you able to give a cause of death for the coroner, do you think? He was treated for sepsis, wasn't he?
Yeah.
Yeah. In the place of metastatic cancer. So you might have 1A sepsis, unknown etiology, 1B or 2 metastatic lung cancer, lung cancer with metastasis, which is essentially. So that could be an option. Yeah. See how sometimes it sounds easy, but when you get into the case, actually, it's a bit more tricky. Yeah. Any clinical governance concerns? Is there anything that you guys thought was a bit of a worry there?
So maybe we could just, obviously, you've mentioned that because you knew there was a consultant who'd seen it, but it does look on the kind of documentation that it's just an F1 who's
Yeah.
seen. And
So it's like signing off the record, like who was it did the assessment, who's written, so around like, the quality of what we write in the notes. Anything else?
Again, I'm not sure if this is like a practicalities and it wasn't included for the purpose of the task, but there's no like verification of death in the notes or anything.
Yeah.
The only documented thing is that one of the nursing team has written passed away. That's it.
So I think one of the F1s got in contact with me about doing a project on death verification. But yeah, we want to write down when we think the patient died when we verified them. It's really important that we write down when we're told that they died. The reason legally we take the verification time, but if it spans over midnight, so say someone died at 11:50, we don't get to see them until 2 a.m. the next day, it can cause our family a lot of upset. So on the certificate we are allowed to accept the date which we are told that they died. So if you're called and you're thinking, oh, I'm not going to get to there for 3 hours, and you know that they died before midnight and you're seeing them after midnight, really useful that you write death reported to me by nursing staff blah, verification time blah. Yeah, and that's really, really useful. And we encourage the site practitioners to do that overnight as well. Cool, thank you, group one. So group two, can you give us a short précis headline of the case, and then again the same, go through these questions. So who's up for group two? Who's the spokesperson?
Yeah, okay. It's a 90-year-old male who's had a collapse in the garden when it was raining, and he was brought in hypothermic, hypoglycemic,
Yeah.
diagnosed with cold sepsis, and died soon after.
So he had cold sepsis, hypoglycemia. Okay. And did you guys think that there was a duty to notify the coroner here?
Nope.
What did you think? So why didn't you think we had to notify the coroner? What was the nature? Did you say it was in the garden?
Yeah.
So he was in his garden. Does it say how long he was there for?
So the ambulance sheet says that he was found at 8 p.m.
Yeah.
But there is evidence that he spent the previous night in the bed. So it's so he's been there since the morning till the time he was found.
Right. So I
But
think it could have been
another,
there.
like
12 hours.
timestamp is that he was very wet, and the rain was raining at 11 a.m.
So we think he might have been outside for at least 9 hours,
Yeah.
maybe longer. So he's had like exposure. Yeah. I can't remember what time of year it was, but
It
May have
was
been cold.
in May.
in May. Okay, so kind of not freezing cold, but not that warm. So there's a 90-year-old chap who's been outside, he's got exposure. Okay. So what are we going to write? Sorry, does it say any information about what he was like before he fell over? Is there any like baseline information about him?
Yeah, so he was failed to score 4.
CFS of 4?
Yeah,
So what does that mean?
independent.
That's pretty good, right? So he's normally could be driving a car, could be doing gardening. So normally someone's pretty okay. So that's quite a significant deterioration, isn't it? So what are you going to offer on your death certificate? So if you don't think it's going to the coroner, what are you going to put down to the ME for 1A?
It's multi-organ failure to brain.
That's okay, you can start with that, yeah, multi-organ failure. So that's a mode, isn't it? Yep, so MOF. Well, don't use these, don't ever use the short name. So multi-organ failure 1A. What are you going to put for 1B?
Hypothermia.
Hypothermia, okay, so exposure, or
Mhm.
we could put exposure, couldn't we? And then what's the cause of that
Collapse.
collapse? So we could say collapse. Should we probably put collapse in garden?
Mm.
Yeah. To give the context. He wasn't severely frail, so we can't put frailty of old age in too, because he wasn't actually frail, he was old. Anyone else from the rest of the groups? Do we agree, what do we think? Is that reasonable? Does that sound?
Do we know why they collapsed?
Yeah, so it's hard, isn't it? We don't know, because it was on witness, wasn't it? He was found down.
In that case, would you potentially refer, because you've got an unknown cause of what's led to this?
Yeah, so if someone isn't at the upper ends of frailty, and say someone is finds transferring really difficult, they're in a care home, and they have a collapse towards the end of life because they're just dying of their end-stage frailty, which we see happening in the community, that's where you could have frailty of old age, yeah, as a cause for a final decline. But if this guy's managing quite well, doing gardening and bits and bobs.
But we don't really know that, and when you're 90, your frailty scores can just fall off the cliff.
Your frailty score is always 2 weeks before your acute illness. So the frailty score is validated as over 65. But you can fall off the cliff, you can decompensate, for sure. But we would need to know why he collapsed. So he may have had a stroke, might have had a heart attack, might have had a PE. So if we had suspicion of why he had the fall, and we validate that, absolutely would be a natural death, wouldn't it? So if it had said, like, oh, he had left-sided weakness, the neighbour saw him, and then he collapsed to the ground, maybe he had a stroke. But it's quite hard to validate whether this is natural or unnatural, because we're saying we don't really know why he collapsed, but because he collapsed, he got exposure, and then he got multi-organ failure. And you're absolutely right to treat him as cold sepsis, because if you're hypothermic and you're elderly, the most biggest killer is sepsis. So they did all the right stuff in A&E. Sadly, he'd been outside too long. So I think for that one, the coroner might decide not to take that for an inquest, because realistically they're not going to get more information to make a decision, but we would have a duty to notify the coroner of that one, because it's the nature of the big change. So they weren't end-stage frailty, and there was this exposure. So if they got sepsis but without a prolonged downtime, it's less relevant, but the fall and the exposure led to the hypothermia and the cold sepsis. So for that one, I think the coroner declined to inquest that one, and we decided on something here for a natural death, but we would notify. Was there any clinical governance concerns that you guys thought looking through the notes that you were
First
concerned
of all,
about?
there's next to none documentation whatsoever, because we basically have 1 page from A&E declared, and then there's this brief note from the palliative care team
Yeah.
that mostly outlines the PRNs and the syringe drivers, but also this frailty score, we've got no justification for it. There's no rationale on where they get this information from.
So how can you, in the notes, has anyone written any collaborating information in the A&E assessment? Is there anything around the function of the patient?
The only thing is that he's got 2 sons who stated he was previously independent, and they're very angry that he's not in the side room on a named ward, and rather than that, he's in emergency floor side room, and the note is mostly about that.
So if someone's independent without care, they're definitely a 5 or less, aren't they? They're certainly not 6.
Or haven't been properly assessed. We cannot know that.
It's very common to be old but not frail,
Yeah.
and you can be frail and young, but frailty score is only validated in 65 plus. But he may well have been a 4, he may have been a 5, because you're right, if you've got chronic health conditions that limit exercise tolerance, he may have been a 5. And it's really important to write down how we get to that, because we know that CFS is done at our front door, and again we'll redo them overnight and things. The quality of them are quite variable. So we've looked at CFS from A&E, CFS from acute assessment, and then when we reassess later, and they're all different. So that understanding their baseline is really important. Cool, thank you. And group 3, what did you guys find for your case? So take us through that one.
Yeah, so this was a 88-year-old lady sent in by a GP for symptomatic anemia, aged about 60 or so,
Yep.
to ACCA for blood transfusion.
Yeah.
Was given 1 unit and discharged with a plan for 2-week wait endoscopy and a further unit, I think the next day.
Uh-huh.
Came back to ACCA, had another unit, at which point she had a reaction.
This was the second one, yeah?
Yeah.
Okay, cool.
And then following that reaction, she had another important detail with the admission was that she also had signs of undiagnosed heart failure, so she had a BNP of over 1,000, as well as significant peripheral edema.
Uh-huh.
So yeah, it seemed as though she had a decompensation following the blood transfusion, went to ITU, was treated with CPAP, high flow nasal oxygen, didn't improve, was taken off, made end of life, and then end of life for 5 days, and then eventually died.
Mm. What did you guys think? Was that a natural death or unnatural death?
We thought it was unnatural because it seemed as though she was clearly well enough to be seen in ACCA until she received the medical intervention of the blood transfusion.
Yeah. So she'd been reasonably okay and then
Yeah.
fell off a cliff afterwards. What did you think about the cause of death? What would you propose to the coroner?
So I think we agreed that in 1A, decompensated heart failure, and then 1B, blood transfusion reaction.
Is there any other medical terms that, and it doesn't matter if you don't know it, because I had to look it up when I scrutinised this one. Is there any terms that we know that the blood transfusion can do that with volume problems?
Well, we're thinking about a TACO.
TACO, yeah.
Yeah, because
Exactly.
in the documentation it's written about anaphylaxis, but it wasn't really a convincing story necessarily.
It's quite interesting, 'cause I had a chat to the consultant about that one, because I was the ME for that case, and there was lots of wheeze, but there wasn't airway issues initially, so it's quite strange. It went sudden change, very rapid, almost too rapid for TACO, and they treated initially as an allergic type reaction, but then they gave CPAP later, didn't they? So there was a bit of a mixed picture. It seemed a bit odd, but I think you could offer either, allergic reaction from transfusion or TACO, and I think in the end we went with TACO side of things. One of the, I think the haematologist suggested, could we offer acute myocardial infarction, but ITU and the physicians felt there was no evidence to corroborate that. ECGs hadn't really changed. I think they did a troponin, but I think that wasn't so dynamically different. So yeah, the patients had a transfusion, so that one's going for inquest. Was there anything that you thought from a clinical evidence perspective that would be worth highlighting? What did you guys pick out?
Yeah, so we thought, our first reaction was that we felt it was quite unusual for the patient to have been accepted by ITU, because what's documented in the ITU notes is that she had a poor functional baseline and that the family had felt that she had quite a poor quality of life across the past 2 years. So I think kind of in relation to that, what could have been improved is thinking about treatment escalation, and probably the fact that she was in ACCA, that wasn't so much at the forefront of people's minds compared to, someone's being admitted to a ward.
Yeah, you're right. So patient selection, I suspect probably ITU felt more burdened to take the patient because, as you said, she'd had a human intervention that had gone wrong, couldn't have been predicted. So then they've tried to put in all the things they can to try and stabilise the patient. Anything else we noticed about the haemoglobin? So was that in keeping with NICE guidance, do you think? What was the haemoglobin before they did the transfusion? And that was before the first one, wasn't it? It might not have been in there actually. Did they put it in before the second one?
I think there are two notices of something 60 and 70, I think.
Yes, and the second one, I think one of the comments from haematology when we were looking at this case was actually, should the patient have been given the second unit of blood or should they have had iron instead because they were above 70? Does anyone know what the indications for the NICE guidance for transfusion is?
I think if it's under 70, you give a transfusion. if it's in the 70s and symptomatic with a transfusion.
And there's the caveat, isn't there, for acute coronary syndrome? Yeah, so if you've got acute coronary syndrome, then it's 80, isn't it? Otherwise it's 70 as your threshold. Yeah. So I think that was one of the queries that came back, is actually, should they have had iron? We know that blood transfusions are risky things, but it was given in a safe environment in the right way. But yeah, so I hope that's been useful, and I think discussing those cases, it seems easy first of all when you're writing them, doing the case examples. Actually, when you're looking at real notes, it becomes a little bit more tricky. So being an ME is an interesting thing, and it is a career path, so people can do that as a portfolio. So I would, if any of you are interested, as you become more experienced, we're very happy to have people down to the ME service. As I mentioned at the beginning, I've highlighted some key reading elements of the cause of death list. We've got the guidance from UK Gov around completion of death certificates, and again the final slide on indications for referral to the coroner, and now linking with your curriculum items. So I hope that's been useful, and I've kept you 5 minutes over, so apologies for talking a little bit too much. Any questions or queries? No? And if you can do the feedback, log into the foundation thing, and if there's stuff that you recommend for next year, please do pop it in and we'll get the talk changed. But hopefully we can recognise that medical documentation is really important, and when stuff goes missing, it's just not there anymore, so make sure that things are filed well as we go through. Brilliant.